Remember my mic. Good afternoon and welcome to this public board meeting. As always, I'd like to start by thanking members of the public who are observing this board meeting, either in person, particularly in person, I'd say, or through the live stream. There are a couple of, before I welcome new members to the board, there are a couple of people I need to talk about for whom this is the last public board meeting. The first is our acting chief executive, Sam Prophet. We've still got 6 weeks of Sam, which I'm very, very grateful for, but I did want to take this opportunity to publicly thank Sam for stepping in at a really very difficult time for this organisation and for leading us and the system with such integrity and compassion. You leave this ICB and you leave the system in a far better position than it was when you took over, Sam. It's been a very difficult period for us all. And I'm just so very grateful for you, first of all, for stepping up, and secondly, for leading with such aplomb. I know that board members and partners across the system will join me in wishing you all the very best in your future endeavours, and we will hope to keep in touch. The other person that will be leaving at the end of October is Stephen Downs, and again I would like to thank you, Stephen, for stepping up into Sam's shoes as the acting Chief Financial Officer. Again, it's a very difficult time, and for guiding us through the last months with such clarity, and also that compassion and integrity, which is really important. So we're very, very grateful to both of you. We will miss you both, but we wish you both the best. I know, Stephen, you're going on to a role in Manchester, so we wish you the best for that. Because we have people leaving, we will also have people joining. So I would like to welcome new colleagues to the board. We have Mark Bakewell, who's joined the ICB as the interim Chief Finance Officer. He'll formally take up his role on the 1st of October, but a welcome to you, Mark, and I know you come from a similar role in another ICB, so you will bring a great deal of experience to us around the table. We have apologies from Jane, but I need to recognise that Jane Scattergood has been made up to acting chief nurse. And again, apologies, but Silas Nichols, I'm delighted to say, is the new partner member for acute, given that Aaron has stepped down from that role, coming as he is to us as chief executive in November. I would also like to welcome Jennifer Riley, who is the ICB Associate Director for Population Health and Place Delivery for Blackpool, and Amy Butler, the Manager for Health Watch Blackpool, who are going to be doing our community story later on today. Thank you both. So in terms of apologies then, I've got received from Steve Igo, Jane Scattergood, Steve Spill and Victoria Gent, as well as the partner member Denise Park. So a few apologies today, but we are quorate. Oh, and Jane O'Brien, as of this morning. Thank you, Roy. Yes. So as always, I would want to maximise our time for discussion. So I do ask executives to be very brief in their introductions. The papers were good, and we have digested them all, so you can assume that all papers have been read, and we should therefore have enough time for good discussions, but I will need to have a very hard stop of 4 o'clock for the end of this meeting. Usually I'm more relaxed about that, but we have our AGM at 4:30 and we need to turn the room round. Okay, do we have any declarations of interest not on the list for today's agenda? No, excellent. Obviously members are asked to raise any declarations during the course of the meeting if they do arise. So now on to the agenda then. The minutes for approval of the 24th of July. Are we happy with those as an accurate record, first of all? Yeah, Jim.
Just make one comment on minute 102.25. There's a paragraph on page... Minute 102.25. There's a paragraph on page 18 which started J-Bill expressed appreciation for the opportunity to discuss cancer services. It then goes on to talk about virtual wards and the presence of unused facilities. I think it should be virtual wards and 12-hour trolley waits, which is the point I was making.
Thank you. Thank you, Jim. Thank you. And those are the only minutes, I think, yes. So we now go to matters arising and the action log. There are 3 actions on the log. The first 2 I propose are closed. Reference 16, the board papers to reflect the voice of communities. We have now got a revised reporting template, which includes a specific section relating to public and stakeholder engagement. Are we happy to close that? Great. And performance metrics, and it's up to us then to, and we'll pick that up in the 3rd point actually, to make sure that that is done in practice. Reference 18, performance metrics to articulate improved health outcomes. The new integrated performance report, I think, is starting to demonstrate that, and thank you for that, Asim. And this aligns as well with phase 1 of the planning framework, which we're under, which is under in work at the moment. So are we happy to close that one as well? Great. And then the ICB values, there were 2 parts to this action, I think. The first is going to be undertaken, so conducting a review to assess how the values are being upheld. There's going to be further discussion through the People and Culture Committee with the OD plan being presented at the October meeting. And I know Jane would talk to that if she was here, but I know that's something that she is very keen to look at in some detail. And the second, in terms of consideration to the incorporating the values and reflections that get at the end of each board meeting against decisions, I would propose that we already have a bit of a debrief at the end of each board, and that we use that as an opportunity to widen the discussion, and that we do that explicitly. So I know that was you raised the point, Debbie, so if you can keep holding us to that, that would be great. Thank you. Happy with closing that one? Yep. Good. So community experience, patient story. So over to you. Thank you very much. Oh no, I think it's Andy. Are you going to start it?
Thanks. So great to have Jen and Amy with us. Thanks so much for making the time. This is, for me, another really good news story which we wanted the board and our public to be able to experience. It comes from Claremont Ward in Blackpool, and it speaks to similar stories that we've heard progressively through this year, similar to what we heard, work going on in Preston and work going on in Barrow. This is a wonderful example of ways that we as an ICB are working collaboratively with our communities, with our brilliant system partners in the community voluntary faith sector, and with local authority partners to really transform outcomes for our population, to improve population health, to tackle health inequalities, to see the demand on our services decrease, but more importantly, people's lives improving in the process. So really looking forward to this story. Thank you both for making the time. Over to you.
And thank you for the introduction, Andy. That's really helpful. So as Andy's already alluded to, and as you'll have seen in the briefing paper, Amy and I are here to talk specifically about work in Blackpool that we've been doing for our health services to work really differently with our communities, particularly in areas where we know people are experiencing significant inequalities and significant disadvantage. So, Mark, would you mind just getting the slides up for me, please? Thank you. We've only got 2. So, as Andy said, this work has started in Claremont. It is not just Claremont, but this is our starting point. So there's a few pictures up here that show Westminster, our primary school, the Grundy Art Gallery, the beach. We've got the Rainbow Quarter within Claremont. Claremont is a really vibrant place. I was with some of our community leaders on Tuesday, and they talk about Claremont being inclusive. We've got the Metropole, which is an asylum seekers hotel. We have got the Rainbow Quarter, and they talk a lot about the hope that they've got for their community. So I really want to show there's some amazing things happening there. We also know there's some significant inequalities. So we have the highest rate of So we have the lowest life expectancy, for adults and women in Blackpool, which makes it one of the lowest life expectancies across the country. We see significant amounts of urgent care demand, and we also see poor outcomes in terms of, So yeah, we see significant levels of urgent care demand, and we also see poor outcomes in terms of our all-age standardised mortality rates as well. So we did some specific work across Blackpool, supported by Health Watch some time ago, where we went out to our communities and directly asked them, what were the things that were affecting their experiences of health and care, what were the things that were potentially driving some of those poorer experiences, poorer outcomes. And we really listened hard to what people said. And a lot of what people told us was that they felt left behind by our services, that there were a lot of barriers to accessing them, that we talk about people being hard to reach, but we don't talk about our services being hard to access. And really what we wanted to do was listen to what people had said and crucially recognise it is about much more than the NHS. We often focus on our issues around urgent care demand, around our metrics, but we don't necessarily look at everything that is going on in people's lives that affects those things. So you'll see in the centre of the picture there, that is our Claremont bus that we have had running, and that is effectively a multidisciplinary team. So on that bus, we've got therapists, we've got GPs, we've got nurses, and we've got our community engagement officers. And we proactively work to identify people who may need support. That might be clinical, it might be non-clinical, but we work to identify those people, meet them where they are, and to wrap that support around them. And I'll let Amy talk a little bit more about the work of our engagement officers.
Perfect, thanks Jen. Can you hear me okay? Yeah. Fabulous. So I think from our perspective, the best thing I can do is start with a story because that's probably what you all want to hear. So a particular resident sticks...
Keep the mic closer to you, they can't hear you.
Oh, sorry. Can you hear me now? Is that okay? Now? Yes. Fabulous. I'll probably shout it then, didn't I? So a particular resident sticks quite closely in my mind and my heart, who we supported. So we found this individual through door knocking, which has been our approach, and you'll see that through the paper, and really proactive outreach. And what our community engagement officers found was an individual who had a lot of unmet needs, a lot of complex health and social care issues, as well as some wider determinants issues as well. But for that person, what was really significant is that they hadn't been in their own back garden for 7 years, and all that they wanted in the first instance was to go in their back garden. So I can probably guarantee that most people in this room would not have thought that that was the main priority for that individual. Actually, the unregulated diabetes would have been the priority. The huge issues with mobility would have been another one. But what we did is we were led by that individual, and we went back to our wonderful team at the bus and we explained some of the issues that were going on. And we said, he needs a rail to get into this back garden, and that is absolutely imperative for that individual. So the occupational therapist came out with us, fantastic, really, really speedy referral, part of our multidisciplinary team. And it's important to note that we are equal partners within that multidisciplinary team, and our input is absolutely valued. And because we had built that relationship up with that person already, we were able to kind of bring the occupational therapist along, introduce them as someone that can be trusted because we are working with that person, and an assessment was done, a rail was fitted as well as other mobility aids that the individual needed. And when we went to revisit that person, not only were they absolutely over the moon and had some faith restored in what the system was doing, we were then able to open a discussion around the diabetes and actually get them booked in for the diabetic review, get the diabetic eye screening booked in that was accessible for them now because they were able to move around easier. Speak to Tracy's team, for example, at Citizens Advice, who've been out with us on a number of occasions, and get their debt management sorted because they disclosed that once they knew that we were there to do and support them in a way in which they wanted, and they were able to have control and make decisions over their own lives. So hopefully that demonstrates our input in this.
Okay. Thank you, Amy. Sorry, can you hear me okay now? I was conscious I wasn't near the microphone either. So as Amy said, we've got this really integrated model. So our community engagement officers actively go out and knock on doors. We do not cold call, we put leaflets through, we tell people while we're there, we're really clear that we are associated with the NHS public sector organisations. Amy's team, I say team, it's 2 people, have knocked on over 600 doors within Claremont over the last 16 weeks. For context, Claremont is around 3,500 houses, so that is a significant amount of coverage. We found around 10% of people have got significant levels of unmet need. So these are people who are not necessarily showing up on our radar. So they are either under services but are not being able to access those or not getting the full benefit from them, or actually they're showing up nowhere in our services. So the gentleman that Amy talked about, he was not on a list, he was not waiting for anything, he was true unmet need. It's been really important that Jason and Siobhan, who are our engagement officers, have got that route into a clinical and public sector team. So twice a week they meet and discuss, and they will say, I've talked to this person, they really need help, we don't know where to go. Interestingly, I always say, one of our therapists said all the referrals have been appropriate, which is a classic NHS term. But the point is that actually we can tell what people need, and people who are non-clinical can go and have those conversations and say, this is really the thing we need to support this person with. And we've seen some huge changes in, I'd say, the culture of our team, actually. So everyone who's been involved is really proactive, really keen to get out there and work with people, but have been really challenged by the role of our CVFSE partners in saying, actually, no, it's not good enough to say somebody's got all of this in place if it's not working for them. We've got to do something different. And actually, it's really interesting now that we've had our GP, Dr. Sarah McAllister, has now joined the team, because she said, this is the work I often don't get to. She referred to it last week as non-clinical case finding. So I just wanted to really bring out the crucial role that our partners and our non-clinical partners have within that team. In terms of next steps, we are taking a really robust approach to evaluation. So that is supported by the Health Determinants Research Collaborative, and Dr. Heather Catt, who is a public health consultant, is working with my team on evaluating the impact, both in terms of what does this mean in terms of demand into our services, but more importantly about what has the impact been for these individuals at the point they were taught to and the point afterwards. And we've got some amazing stories and feedback, and a lot of the themes coming through have been just thank you for listening and thank you for caring, and then something being delivered back in that up. We will be rolling out across 4 other wards in Blackpool over the next few months. So we are starting in Bloomfield in December is our next one. And we're using this to build on a Lancashire and South Cumbria approach. So I want to be clear, this isn't an approach on its own. Andy mentioned some of the other examples at the start. We've got the work ongoing in Blackburn Central Ward with the Health Equity Group, the work happening within Morecambe Bay, and the work in Rylands Estate in North Lancashire, to name a few. So this is just part of that. But what I would like to say is it really evidences impact for individuals, and actually it really impacts positively on the system. Yeah, hopefully that covers what you need, Andy.
Perfect, thank you.
Thank you very much. I always love these stories at the start of the board. It reminds us what we're absolutely here for. And I think you covered a number of the questions that I would have asked, actually. I was really pleased to hear about the MDT and everybody's equal role in that, which is fundamental. You are assessing the impact of it, which is also very important, and we're looking how to spread it across, presumably reflecting the needs of different communities. So thank you. Really, 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 really lovely presentation. I can see hands shooting up. Jim.
Thanks very much. Yeah, I agree absolutely what you said. It's great to hear these stories, but the modern stories, they're actually providing care, and that's really important. And it was also really encouraging to hear that it's being rolled out, because I think the issue previously is we've heard the stories, but it's almost like nothing else happens from them. But this is being rolled out, so I think that's really good news. I also noted, though, that you didn't mention resources. Almost every time we have an item here, it's about lack of resources. You haven't mentioned that issue, so I guess you have got a problem with resources, but you're obviously getting by and doing what you need to do without vast sums of money, basically.
Would you like me to come in on how we've resourced it? So we have funded this through the core population health budget in the first instance as a test of change. So that is within existing money that we've repurposed to put this in. The way that we're planning the programme is it forms initially a 12-week test of change. So we put in a certain amount of money to kind of say, right, let's double run this. The point we're at with Claremont now, we've said, actually, that isn't what it is currently, because you can step things down and say, actually, this is just a change to the way we work. So the bits that are additional are our community engagement officer. They are having an outreach clinical van. Actually, some of the core work that happens within community services, that's about some of our redesign as well. So I think when we work through resources, there may well be that we need to review how we do this, but right now we are doing it within our existing budget for those communities that need it most, and evaluating the return on investment that gives us. Okay.
Thank you, Jim. I've got Roy, then Debbie, then Tracy, and then Chris.
Thanks, Chair. And firstly, could I just say I'd like to concur with the remarks you made earlier about the report itself and the presentation. So thanks to Jenny for thank you very much for coming along today. I am aware of Claremont Ward, and I know it reasonably well, and I know the work that's been going on in there. It is excellent, the report, but you'll also be aware that Claremont Ward is one of the 7 priority wards in the Better Start scheme that's running in Blackpool, the initiative. And it would be really great if we could just, as part of this report, or perhaps as a future report to this meeting, if we could look at children and young people within the ward as well, because certainly deprivation, does affect children and young people and families, and you're talking about the men and women in here within the ward, but yeah, children and young people, they have life expectancy at birth. You can say those, that life expectancy thing. I think it's getting better, to be honest. I've seen the figures, and they are getting better, but it's the deprivation issues, and that affects, as I said, the whole families, and specifically, I think, children. And sometimes they can't speak for themselves, and they need people to speak for them. So I think it's really important that we listen to that, and if we could have part of that as a future, perhaps a presentation or report, that would be really excellent. So thanks to you, Andy, and thanks for coming along again.
Debbie?
Thank you very much, Jennifer and Amy. It's a really good presentation. I'm the Chief People Officer, so I was really interested in what you talked about, team and culture. I think this is a really good example of an integrated workforce working across organisational boundaries. So I was just wondering if you could give us 1 or 2 tips on how you've made that working effective, please.
Amy, would you like to take that one?
Yeah. So I think from our perspective, having lived experience valued and setting that culture and that premise from the outset has been really important. So one of our engagement officers is a Claremont resident, absolutely is aware of the context and the wider needs that people are experiencing. So being able to set our stall out from the beginning with those that are involved to say, actually the lived experience input and the clinical input, when you marry them together, both become stronger, and we really, really need both. So I think that has been really important. I will say we haven't gone through this without experiencing challenges. We absolutely have. And I think clear operational leadership across the organisations is the bit that's key. So myself and the PCM manager have sort of had to step into the fold where we probably realised over time there was a bit of a gap. If we could go back and do something differently, I think we would put that in from the beginning so that we make sure everyone from all the different providers is absolutely on the same page and can deliver things in the same way, if that makes sense. So those would be my top 2.
Thank you. Tracy?
Thanks, Jen, Amy. Well done. How you managed to condense such a huge amount of work into a very short presentation. You did fantastically well. 2 things from me. I think top of my list would be, when we talk about why this has worked, is because of the people, not least the 2 of you, but the people around this project and the work you've all done. Your enthusiasm, your absolute tenacity of never being taking no for an answer has been one of the success factors in this, and there's no doubt about it. But I think the thing that I would really put a spotlight on with this work is, especially for us as a board, at the moment we're organising services that are leaving people behind, and people are slipping through the cracks in the services that we're providing. Even when we think they're there to meet the needs of certain people and communities, they're not. And what certainly Amy's team have done is absolutely put a spotlight on that and say, until we come together and we give permission to people to do things like sort out somebody's garden. I mean, whose job is it to do that in our system? Yeah, that happened because there were people who said, we know this is a barrier to this man's health. We need to do more of this. We need to do more of breaking down those barriers between teams and giving people permission to do the things that they don't think are their job. The other thing I would say as well is, when it comes to resources, this wouldn't have happened without resources. But again, what has happened is resources have been used in a different way. And people have come together and said, well, actually, I haven't got any resource to do that, but I'll take a little bit from over there and I'll make that happen there. And again, that's the will of people who see the need. I think it's going to be really interesting when we get the evaluation and we understand how we can compare an area like Claremont with Bloomfield, with Park, and maybe with some of the other areas across our system, where there's going to be a wealth of intelligence. And one of the things I would say is we absolutely need to use this in the future to understand how we design services to meet people's needs, because we're just not doing that at the moment.
Thank you. Thank you, Tracy. Chris.
Cheers. Thank you, Chair. Thank you very much for the presentation and the paper. My name's Chris Oliver. I'm Chief Executive of the NHS Mental Health Trust that covers Claremont. Can I just ask two questions, if that's right? So one of our services, and one of the main entry points into mental health services, is through the initial response service, so 24/7 call. Trying to publicise that is always, ongoing work. It takes 60,000 calls a month, but we can always take more and either bring people into secondary health, mental health, if that's required, or signpost. And I wondered if we could just join up teams around when you're doing your door knocking. I think there's something we could team up with there. We've got community roots team, and I could link in with Paul Jebb around how we can do maybe some great work together on that. Would be really exciting, I think. So yeah, just a massive thank you, and if it's okay, I'll link you up with a couple of people.
Is it okay for me to just go? So I was going to say we've got existing pathways into the IRS as well, and we've had a lot of conversations about the involvement of Lancs Care within the programme. We've found mental health issues to be a significant challenge within the area, but those pathways have worked well. For our next stage, which is Bloomfield, we're opening some specific conversations with Dom Hudson in the first instance, because we know that in Bloomfield we are likely to require that level of input actually within the bus. It might not just be a pathway, and it might not be a bus, I hasten to add, an outreach model. But yes, so we're building that in for Bloomfield based on our population health needs analysis as well.
That's fantastic, yeah, and Dom Hudson's brilliant. And we have a bus also, so if you need initiative, we can provide that. So thank you.
Great, excellent. Kath, final person.
Thank you, thanks Chair, and congratulations. Yeah, it's absolutely great work, and you've got me really kind of thinking about some of the stuff that's already happening in Westmoreland and Furness, and I think it's a similar point to Chris was making. So this screams to me of community power and thriving communities, two big programmes of work that are happening across Westmoreland and Furness, but thinking about particularly South Lakes and Furness. We have community engagement offices in the council as well, so I think there's a real opportunity for us to link up. So I've just jotted my email address and whatnot down on there, so if we could get together outside, I think there's a great opportunity to build on other resources and grow what we've got. So that sounds great.
Excellent. Well, thank you all very much. Stimulated a lot of debate and clearly some further improvements to what we're doing across the system. Thank you very much indeed. You're more than welcome to stay, but please don't feel you have to. Okay, so we now move to the more formal part of the session. Firstly, my chair's report. I'll take it as read and very happy to answer any questions, but I did just want to say a few words, particularly about to recognise what a very challenging time it's been over the past few months for everyone across this organisation and indeed the system, as we've had to try and address the issues raised in our undertakings and through the Recovery and Support Programme, at the same time as dealing with the uncertainties associated with the transition to the model ICB, as well as doing our day jobs to the best of our ability. As we've navigated these challenges, I do know that Sam, because we've had these conversations in many, many boards and committee meetings, Sam and the executive team have put our values at the centre of how they've taken decisions. And I just wanted to say how proud I am about how everybody has responded. The commitment and focus on what we're here for and how we behave is starting to pay dividends. We'll hear later about the financial position, but despite ongoing risks, we still remain on track to deliver the plan that we committed to. And the feedback from the RSP team and the region is very positive about the improvements that we're making. So I'm not saying we're there, but that commitment and hard work is starting to pay some dividends. And the other thing is the ICB transition. There are huge uncertainties remaining, particularly around timings, but we have made a real lot of progress in our thinking and understanding of the different functions that we need and how they need to interact. And we're starting to refine this understanding as we embark on the engagement process that is currently underway, and as we commence our medium-term planning in line with the planning framework that's later on in this agenda. The engagement with staff over the next month or so is really important to us. It's an opportunity to explain our thinking to date, but also to make sure that we don't miss insights from those at the front line, so that we shape an organisation that works, delivers for our population, and provides a meaningful and enjoyable working environment for all of us. I know that lots of people have signed up for these sessions, so going back to where I started in this little homily, this is another testament to the commitment and passion that everyone in this organisation does have for getting it right. Thank you. Are there any questions on my somewhat less interesting report, but nonetheless important? No? Okay, I'm going to hand over now to Sam.
Thank you, Chair. And this is my last formal board meeting, so I am feeling a little bit like mixed emotions about this, but I think it was very kind of you to acknowledge that at the beginning, Chair, and I just want to say a massive thank you to everybody who supported me on this journey, all the providers, our partners, and all of the staff and my executive team, everybody that I'm working with. So thank you so much, and I too wish Stephen all the best in his role. Is in my report today, and welcome very much Mark to his new role as well on the 1st of October. I suppose I just want to echo some of what Emma's said and our chair said around this change process we're going through, and it is in the report that we are going through significant change. This is probably one of the biggest resets we've seen in the NHS, but there's so much positivity to it, but in terms of the 10-year plan, and starting off really with the Darcy report, and then a huge engagement with the public that's led to this change. So I think what's coming out is really positive, and I think the blueprints that are setting the way for region and the way that we will become a real strategic commissioner is all the right stuff, but I can't take away the fact that this is significant change is impacting on our people, and that's really hard, and we're hoping to get better timescales for some of this change as we go through the rest of the year. But I just want to say a massive thank you, because what I'm seeing across the whole organisation is, despite all of this, and despite the anxiety levels and the distress this is causing to many of our people, we're seeing some huge progress. And as Chair's just said, we are on plan at the moment. We are seeing progress. We're seeing some really good things still happening, not least some of the stuff we've heard this morning, but a lot of that prevention agenda out there is still happening with our lung checks and our work well and a whole range of other things, but also, you know, we're dealing with commission intentions, we're building relationships, there is a huge amount happening, and, you know, I know the finance team are putting in a new ledger in the middle of all of this. There is just, it's like the day job doesn't stop, and yet people are still delivering, and I just really want to acknowledge that, because we are really all very concerned about the level of anxiety in the organisation and our 800 people, but across the system as well. But we have got a prize at the end of this, and I do think the future will be really good, but it's getting there, isn't it? And I just wanted to acknowledge that, really. And I suppose I didn't want to go through all my report, I'm assuming everybody's read it, but I did want to just say that how much I really enjoyed my visit to Darien House. And I know that people have heard me say this, but I was so inspired by the work they do there, and Dr. Andy Knox attended with me, along with a medical student who was shadowing for the day, who was lovely. And we had such a lovely time to visit them. And I think it really brought home just how important the hospice community is, and the work that they do is amazing. And when we start to build our clinical strategy going forward, which is our next step, we absolutely have to embroil that in with hospice, along with a whole range of other organisations. But our hospice sector could offer so much more, and we could help so much if we get that right. So that's a big takeaway for me. But I just also want to plug their documentary Paul Woodward, who's the father of Kalal, who was supported by the hospice, is actually a filmmaker, and he made a film called The Little Things, and it's out on Amazon Prime now. I'd just encourage anybody watching this or listening today to just have a look at that, because it dispels a lot of myths about the hospices and just the brilliant work they do. And I was blown away by it, and I just think thank you to everybody there and all of our people that work across the system in this area, because it's amazing. So I just wanted to say that, and it was in the last sort of month or so of me doing this role, I have to say it was one of my best days. That I just loved it. It was just so joyful. So thank you to everybody involved in that.
Thank you, Sam. Are there any questions on Sam's report? Yes, Sakthi.
You'll be pleased to know it's not a question, Chair, but I just wanted to thank Sam for her presence and for steering this organisation and keeping the communication and engagement open with a wider set of partners during this difficult time. And a personal thank you as well for what you've done in leading this organisation, Sam, and I wish you well for the future.
Thank you.
Okay, I'm going to move on now to the People and Culture Committee Escalation and Assurance Report. Jane, as I've said, has given apologies, so Rory is very kindly going to just give a summary.
Thank you, Chair. I'm not sure how I follow Sam's report, actually, but I will try my best. Yes, the paper on the People and Cultural Committee is for the board to accept today, as is the AAA reports, which I won't go into detail on and will take as read. However, I do want to just refer to a couple of things in there that I know Jane would wish us to hear. The first one is on one of the alerts, which talks about the challenges of recruiting and retaining a workforce. When we have a number of fragile health services, which includes rightly volunteering and losing those relationships that we've talked about in deprived communities. So it's really important that we consider that as well. And I think Jane's favourite subject is the next one, research and innovation, and she really wanted to highlight the importance of that research and how it needs to be driven by this board and by our executive team. But also about the collaboration that's being discussed with the Greater Manchester and Cheshire and Mersey ICBs as well, which really, as she says, it highlights the importance of that research and the drive that it needs to be given. Regards to the third thing on the alerts, which is the transition plan. So we did receive an update on the transition plan, and as you're aware, we're going through a period of perhaps I wouldn't call it instability, but we are going through a period of change, and Jane's kindly wrote a few words for me. If you don't mind, I'll read these. So the immediate priorities for our committee, for the People and Culture Committee, are to support staff morale, health and well-being, extremely important, as we know. And when we transition to that new model of the ICB, to be assured that that transition's well managed, and there an effective transfer of those system responsibilities to the region when these do become clear. So we are unsure, and there is a lack of certainty on the transition implications at the present time. That situation obviously is not fully within our control, but it does have a negative impact against a background of low morale, and we do plan a deep dive on the health and well-being in our upcoming committee to be assured of the implementation of the improvement plan. And similarly, we await clarity on what the ICB's workforce responsibilities will if they transfer to the region, and have highlighted the need to ensure system-wide working continues and relationships are maintained. The committee identified the risk that the short-term focus on restructuring may divert us from thinking longer term about our strategic objectives related to the workforce across the system, including, as I've already referred to, recruitment and retention challenges. And similarly, we discussed the need to continue to support research and innovation again, which I've already, but Jane won't mind me mentioning it twice, across the system and exploring the benefits of collaboration across the North West. The EDI report was recommended for approval at the last board meeting, and the committee will be receiving an EDI action plan as well as an update on the people plan at the next meeting. The next meeting, Chair, is scheduled to be in September, I think this month, October, thank you, Debbie. The minutes of this meeting, which is of course with the July meeting, will not be coming until those minutes have been approved at that meeting, and therefore those will not be coming to the board until November, which is rather a long time, I think, between committee meetings for those minutes to come to the board, and I think things change in that timescale, Chairman. So perhaps I'm just wondering if we need to think a bit more about minutes coming to the board in a more timely manner, if that could be. But the problem is they have to be approved by the committee, of course. So I just think it's something
that's why we have the AAA reports.
Of course,
yeah.
absolutely.
Yeah.
Okay, I'll stop there, Chair. Thank you so much.
Great. Thank you very much, Roy. Any questions on the People Committee? Debbie, was there anything you wanted to add on that? No? Thank you. Thank you very much indeed. Okay. So we now have the Working with People and Communities, the Insight Report. Neil.
Thanks, Chair. So I'll be fairly brief on the report, but the report covers the work around listening to local people and some of the insights and engagement we've done since the last board meeting. I think section 2, it's important to note that the ICB has currently got its first live public consultation. We're in week 12 of the Shaping Care Together consultation. But I did want to highlight in point 2.4 the extent of, as well as some of the public events. My team have spent a lot of time out and about in West Lancashire, actually going out into communities similar to the example that we heard earlier around Blackpool, actually working with a lot of community partners, community groups, and actually really spending time listening to people as well. Not just about some of the consultation, but it's allowed us to look at how do we capture insight that plays into some of the neighbourhood working as well. So I thought that was important to note. In section 3, it's important that we have received a petition signed by 13,000 people relating to the intensive care at Furness General Hospital. We have committed to a series of a public engagement exercise over the next 8 weeks, so we will be speaking to lots of people again and listening to people around that piece of work and making sure that feeds in as well as the petition we've also received. Section 4, I think, is really important. That one of the other places where we hear insights from our communities is through individual complaints. And I know, Chris, you asked last time about the link between some of those patient experience teams, and this is one of those where that happens quite considerably. You will see that there is an increase compared to this period last year of complaints and concerns that we're receiving, but I can reassure that there's a lot of work to actually listen to some of those, make sure we're responding appropriately, and also learning lessons working with our different teams as well and feeding those in, and considerable work going on across that team as well to make sure that we respond to those as quickly as possible, although that sometimes can be difficult. I think section 5 builds on some of the outreach discussion we've already had as well, particularly around Know Your Numbers Week, and the partnership work around that has really made that possible. So working with leisure centres, community partners, voluntary sector organisations, pharmacies, leisure centres, really going out to where people are, and there's a real focus at the beginning of this month around Know Your Numbers Week and making sure that we're delivering blood pressure, but again those opportunities to kind of have wider conversations with people about what matters to them, and I think it's important to recognise the work that's been done across that team on that piece of work as well. And finally, section 6 just describes some of the steps that we're taking to learn and promote good practice in strengthening patient voice in general practices. We recognise general practices are very busy, but some of their patient participation groups are a really good way of them capturing intelligence, and we are working with some of our volunteer citizen advisors and making sure that we try and capture some of that learning and then embed it into some of the work we do going forward. So happy for any questions on that report, Chair.
Thank you, Neil. Any questions for Neil? Tracy?
It's probably a comment more than a question, Neil. Thank you for the report, really comprehensive. I think probably it's much wider, I think, now, isn't it, your remit, in terms of it's not just about patients, and I really welcome that approach, and some of the work that you described around how you're engaging with people who maybe aren't through the usual routes, I think will make for a much better consultation, far more insights, and I think you're really picking up on some of that. So yeah, I think the approach very much welcome. Yeah.
Thank you, Tracy. Any other? Yes, Sam.
Thank you, Neil. It's a good report, as always. And I think, I'm just thoughtful about Jenny and Amy's presentation this morning. And what struck me with that is, we're looking into this new operating model, aren't we, for us being a strategic commissioner. And the whole premise of that is built on us really understanding our population health needs and then commissioning for that. And we're doing lots of thinking around BI, information, data, to try and drive our commissioning decisions. But actually what Jenny and Amy described was how they were gathering a lot of intelligence through the work they were doing on engagement. And it made me think, when they were speaking earlier, how much we need to be capturing that. And I suppose and you've just mentioned it again now, so that has prompted me to sort of just, I suppose, make the point, but I don't know whether you want to make a comment on it, but how are we capturing that to make sure that that does become really good intelligence that we use in our commissioning agenda as we become a strategic commissioner?
Yeah, can I come back? I think there's two elements to that. And I was quite fortunate to spend Friday in Claremont Ward with Amy and Jen, actually. And I think some of the best insights that we have, or some of the best work, is where it's actually continuously part of the model. So actually people are using those insights on a rapid basis of actually doing something about it in terms of, we know that people are listening to what people are saying, because that model on the ground in that neighbourhood is really working, where those services genuinely value certainly some of those colleagues who are going out and listening to people and doing something about it. But then there is something about how do we then look at trends across the system and across the organisation. I think this time we've done much better at making sure that the commissioning intentions is absolutely informed by some of that public voice. We held a session with Healthwatch colleagues and voluntary sector colleagues who've done a lot of work on outreach, and we've made sure that actually looking at what are those key things that we're hearing consistently, and we know it's about improving access, making sure that we're doing things locally in communities where people are, and certainly there are some issues as well around how we join things up. They're absolutely built into some of the process around commissioning intentions. Hopefully when that work emerges, I think we'll see it. And I think finally the outreach and the way we go about it has definitely changed. So some of our teams, our cancer teams, and I think our women's health teams now, are working with voluntary community and faith sector partners and colleagues like Healthwatch to do genuine outreach, where we're going and engaging with people in different ways. And I think it's important that we feed some of that back, and we make sure when we are looking at the way we commission and look at services, we're genuinely taking that on board and doing something about it. And we can definitely see again that slight culture shift of our teams really genuinely wanting to do it. In the office yesterday, I heard from one of our clinical colleagues saying that some of our volunteers who were in some of our meetings as part of looking at how we do things just changed their mindset of actually making sure that they were looking at things from what is it like from a people's perspective. So I think a number of elements of what we're doing build up to the picture, but there's obviously a lot of work to do, because we've also got communities that absolutely we described before don't feel like we're meeting the needs, don't feel that we're doing that. So and then we've got some service changes that we need to make sure we follow processes but really involve people in the right way. So I don't know if that kind of answers your question. It's multifaceted, I think.
Thank you. David.
Thank you. I'm just wondering whether or not we've managed to tackle the issue of having information available about our patients that can be used across the different agencies. So we're hearing really great stories of kind of coming together. But I'm just wondering, have we cracked that missing piece of the jigsaw where we're all using one system, all accessing the same information, or inputting information into a system that other colleagues can see? Because that's been a barrier for many years, hasn't it?
Are you able to handle that, Asim?
I think I agree with that statement. It has been a barrier. We have just, I think in this room, and Tracy will remember, we had a session with the voluntary sector and other sectors around how we tackle that. And we have some real good capabilities. We've got the Lancashire and South Cumbria System Intelligence Service, which provides sort of the NHS side of the things. And there is a desire to input some of the voluntary sector data into that. But sometimes we get stuck with some of the information governance issues, and that should not be a barrier. We need to work through that. So I think we definitely have the capabilities, but we just need the drive and determination to make it happen. But it's definitely something we can pick up and rejuvenate.
Thank you. Good question. Thank you. Andy?
Yeah, just to come in further on that, Asim and I co-hosted a digital roundtable together last week, looking at exactly this kind of issue and how we do better share information with partner organisations as part of our clinical and digital strategy moving forwards. It is a really big piece of what we want to be able to achieve, and certainly putting a lot of dedicated time and thought and energy into it. And also some of this is actually about, this is what neighbourhood working looks like in reality. So the work in Claremont is quite early, but if we talked about, for example, what's happening in Poulton Ward in Morecambe, where we have a piece of work called Friendly Faces, rather than frequent attenders. I like that. People have friendly faces, we get to know them really well. Actually, our multidisciplinary teams in neighbourhoods are sitting down and are sharing information, and that information, because of the relationship, is now being fed into the GP record in a way that can be recorded better. Now, not everyone's able to access and see all of the system at the same time, but we've got a really clear path ahead in terms of some of the IG and governance stuff that needs to be sorted. A lot of this is actually about governance and IG and agreements and getting things signed off at appropriate levels. So we're on a piece of work now with One LSC and Stephen Dobson around what are the steps we actually need to take to achieve this piece of work. And he is lining up a timeline for us so that we can begin to get through those barriers and enable our teams to work more effectively in neighbourhoods and places.
Good. So that was not in the report, but it was a useful area, and I'm pleased to hear we're doing some work around it. And it's also quite encouraging that it's not technically limiting. It's about relationships again, isn't it? It's about getting the working practices. Okay. Thank you, Neil. Great. So we now move to performance overview. I've changed the agenda slightly this time. We'll see how take the feedback afterwards as to see how it plays. But we thought we'd start with performance and how we're doing today, and then work more towards the strategic side of things afterwards. We'll see how it goes. So we first have the Quality and Outcomes Committee Escalation and Assurance Report from Sheena.
Yeah, thank you very much. So the report you have to consider today covers two of our meetings. The first of those was the 6th of August, and then we had a subsequent meeting that was held at the beginning of September, on the 3rd of September. So what we've done here is to take our usual approach about alert, advising and assuring the board. Rather than go through everything on the report, I'll take that you've read it, but I just wanted to pull a couple of things out from the report. The first of those is about all-age continuing healthcare, and you've heard already in the report from Neil around the increase in issues raised about people's experience of that service, and also some MP letters. And what we have got through the work of the ICB is a deep dive to seek to understand what are the issues that's being raised there, are the themes, what's the learning, and so that has been commissioned, is ongoing at the moment, and we'll come back to the Quality and Outcomes Committee, and we'll of course report that back to the board when we have that. The next bit I just wanted to advise the board about was, you'll have seen in the media the new NHS oversight and assessment framework, and we had a really useful presentation about how that is developed, and really had a much better understanding about what are the different metrics are in that, so we can use that going forward to understand quality and outcomes in relation to the providers that we commission services from. The last thing I just wanted to mention on that update was around the review that the board had of the provider annual quality accounts, just to say that those had all been completed, and they were all compliant with the issues that we need to really see from trusts in terms of understanding both their work they've been doing around quality in the previous year, but even more importantly about what their work areas were for the coming year. The second set of assurances or alerts that I wanted to bring to you was the meeting on the 3rd. I just wanted to pull through a couple of things from that. One was around the issue about biochemistry blood processes at East Lancs Trust, and just seeing that action was being taken to mitigate the challenges there were around some workforce and transportation issues that's impacting on general practice time and patient experience. The second thing I just wanted to mention as well was around thinking about the model going forward for community pharmacies, and that bit around making sure that there is some planning nationally around the workforce to support that prescribing within pharmacies going forward. And then finally, you'll have seen in the first meeting we saw that we had the development of the integrated performance reports, and we had, I'm absolutely delighted to say, the first of those new integrated performance reports at our Quality and Outcomes Committee, and a huge thank you to the team that's worked on pulling that through. And that was a really, really useful bringing together of an oversight of quality and performance, so that as a work committee we can really start to think about the outcomes. How are we ensuring that our population experience care in the most effective way that they can, and to really have that oversight of that. And I think that's really going to serve us really well in terms of how we start to develop that committee, both for the work that we need to do as an ICB now in our assurance work, but also even more importantly as we go forward as strategic commissioner. So just really wanted to mention that. Thank you.
Thank you. Thank you very much, Sheena. Any questions for Sheena? Yes, David.
I'm really interested in the deep dive that's going to happen around the continuing healthcare, and I'm not sure whether to bring this in this part of the meeting or in the performance report, but I guess when we're looking at that deep dive, I'd be particularly interested to understand, you know, what's the experience of people when they become ineligible for their support. Either that's because they've been assessed and they're not eligible now, or they were eligible and they're becoming ineligible, if you like. So I'd really like us to look at that, and also what then happens to them. Where do they then go? How long do they then wait for the appropriate support that they may need? So if that could be featured, I think that would be really good for us to understand. And so what happens to people after, you know, the NHS has said we can't help you anymore.
Thank you, David, and certainly we'll take that consideration into our work going forward. Thank you.
Yes, Kathy.
Thank you. So yeah, just picking up on David's points. So there's a lot of work going on at the moment with the directors of adult services from across the whole Lancashire South Cumbria patch, working closely with Jane Scattergood in relation to continuing healthcare, because it's a concern that we also share. We've likewise received letters from MPs and people who are distressed and wondering what happens. So I think there's a lot of work underway, but I think it's just ensuring, isn't it, we're keeping people absolutely at the heart of what we're doing. And Sam, you and I have had conversations as well, so I am reassured about the work that's being done.
Thank you, Kathy. Any other questions for Sheena? No, thank you very much, Sheena. Okay, so we now have the integrated performance report.
Thank you, Chair, and thank you, Sheena, for the comments around the integrated performance report. So what you see today is the summary of the document that goes to the Quality and Outcomes Committee, and he addresses the changing metrics that we see in the new NHS oversight framework, but he also introduces outcome, quality and health inequality metrics. And health inequality metrics are really important because in Lancashire and South Cumbria we face some of the highest level of deprivation than national averages. So I'm going to take the paper as read, but I'm just going to probably just select a few domains where there has been some movement, and I think where we do need the right focus and consideration. The firstly is elective recovery, and we always talk about elective recovery, and there's a lot of good work happening in this domain. So, for example, over 85% of relevant procedures that are sort of subject to day cases are delivered as a day case. So these patients are not staying overnight, which is better for the patients, and resources are used more efficiently. Our theatre utilisation is amongst the strongest in the country, and our pre-referral advice is meaning a third of our referrals are being managed without needing hospital care. But saying all of that, our demand continues to increase, and our waiting list remains nearly at 244,000, which is near enough sort of been static over the last 18 months. Long waits over 52 weeks remain above trajectory, particularly in gynecology, gastroenterology, and oral surgery, and we also see variation between providers. So there has to be and continues to be a focus on backlog reduction and also looking at expansion of our community alternatives. Diagnostic performance, and again, we've discussed this previously, this is an improving position, and we now see our position sitting above the national average. So waiting lists are shrinking overall, and with some of our providers doing really well. So East Lancashire are in the top quartile of performance, I think 15 out of 130 plus providers. But we still see variation, and some challenges remain in Lancashire Teaching Hospital, particularly for specialities like colonoscopy and echo. Our community diagnostic centres, which I've covered here in detail previously, are not running at capacity, and that's been the case for a while. And this is, again, just to remind the board, a key national priority. It further supports elective recovery, and it alleviates pressures from our acute services. So there is some work happening around targeted recruitment to make sure our community diagnostic centres do run to capacity. I'm not going to cover urgent and emergency care, as Craig's going to cover that as part of his winter planning. Just last couple of areas. I want to cover cancer, and an area we've not covered before in the report or in my narrative is the Pharmacy First initiative. So cancer, I covered this in quite a bit of detail at the last board, but I think it's important when we consider cancer or cancer performance, we need to understand the context we are operating in. Lancashire and South Cumbria has a higher cancer incidence and a prevalence compared to the England average. That means there are more people being diagnosed with cancer in Lancashire and South Cumbria compared to the England average. Premature mortality is also higher. And the reason that is important, cancer is closely linked to deprivation, lifestyle risk factors, and smoking. 31% of our population live within the 20 most % of disadvantaged communities in the UK. And this increases to around 70% for Blackpool. And we heard from one of our wards previously where death from avoidable causes is the highest in that ward in Blackpool. So it's really important that we understand the context that we are operating under. And people in more deprived areas, there's more prevalence of smoking, and there's less likeliness of attending screening. So this is the context that we have to look at our cancer data with. And saying that, at the last board, I took the board through in quite a bit of detail around our ambition for that is in the long-term plan around early diagnosis, which is really important. So by 2032, the target is 75% of our people with cancer will be diagnosed at early stage, which is stage 1 and 2. And that means when the cancer is localized and the spread is limited. So although performance historically has been in the bottom quartile, what we can clearly see is an improving position. And I mentioned previously the number of schemes that are taking place with support from the Cancer Alliance, ICB, voluntary sector, early diagnosis, cancer navigators, cancer awareness, lung screening. And specifically around the lung screening program, we've seen a really, really positive impact on the proportion of lung cancers diagnosed at early stage, particularly in the areas where we have implemented our lung screening programs. So in May 2025, the latest data is showing 41% of our people with lung cancer are diagnosed now at early stage, which for the first time is just above the national average. So these kind of initiatives are making a really big impact. So this screening program is live in Blackburn with Darwen, Blackpool, East Lancs, Flyde and Vire, which has seen a 12% increase in lung cancer diagnosed. And 82% of these cancer diagnoses has been in early stage 1 and 2. So that's 400 cancers diagnosed since the program has been live. That's in 2021. And that just sounds like a number, 400, but that's 400 people and their families that now have a better outcome that would not have been there potentially if these screening programs were not taking place. And we've got loads of patient feedback and stories that says that. Yeah, 400 patients. So we need to know more of this, and it's having an impact. And this program is one of the best performing programs in the country. And what does it entail? It entails a mobile CT scanner that is placed in a supermarket or car park that is in the most deprived and disadvantaged communities. And these things will be helping people from Claremont and wards like that. So I just wanted to make that point because there was some feedback on the back of my sort of narrative last time, but it's just really important that we don't lose the important work that we are doing. And lastly, the Pharmacy First programme, which the intention is that we shift the pressures away from GP practices so people can see the pharmacy for common conditions like ear infection, sore throat, skin problems. And we're doing really good in terms of uptake in Lancashire and South Cumbria. And our position is above plan. So minor illnesses, we're running around 5,000 referrals over the last 7 months. And also medicine supply, we're running similar numbers, 4,000 to 5,000 referrals. So these schemes are intended to take pressure away. So both the cancer and the Pharmacies First is that shift left around prevention, and also when we need sort of support, how do we get that closer in our communities? So I'll leave it there. The paper is comprehensive. It covers many different domains. And if there's any questions, I'm sure I'll be able to sort of take them forward with help from my other executive colleagues. Thank you, Chair.
Thank you very much, Asim. That was a really, as always, a great summary. Thank you. So, lots of hands. Sakthi, and I've got a couple over here. So, Debbie, and then Andy and Jim.
Thank you, Chair, and thanks, Asim, for highlighting the great work that's going on, especially in preventing illness. In preparing for this board, I was just comparing the scorecard from the last board and this board, and I just noticed some changes, and I just wanted some clarification. There is a whole section on prevention, clinical quality outcomes from the last board. It's not featuring on this board. So smoking at the time of delivery, childhood vaccination, management of high blood pressure, screening for cancer, early stage diagnosis of cancer, all feels really strategically important as key performance measures. So I'm just wondering, will it be back on the board's assurance framework? Because that would be a strategic way of monitoring things. That was my main question, really. Yeah.
So thanks, Sakthi, and it's a good spot that you've seen that. So we did debate because there were additional appendices that we had included that looks at what I was describing before, the new integrated performance report. And we will bring it back, and I think it will be actually more aligned to our strategic priorities. The reason we removed it needs a bit of explanation in terms of moving from the old sort of dashboard going into the new framework. So it will come back, but the way we will do it is probably bring back different sections. So I've got time then to explain what these metrics are saying. So it's sort of purposeful, but there will be something that will be added back, which will be actually better, I'm hoping.
Thank you. Debbie.
Thanks, Chair. I'm interested in Pharmacy First. So I was really pleased to see in the report that the level of demand that's there, because pharmacy services do such a brilliant job, and they're just so key in terms of people's health and well-being. not declaring an interest, but my local chemist is amazing and offers this service. Just bang it, I won't mention the name and embarrass them. But they do such a brilliant job, and I've seen myself when I've been into it for sort of regular medicines, people going in and then promoting the service, and it then being taken up more and more. So I guess I'm interested from an equity perspective. So is there a sense of how much coverage we have? Because if it's a great service that can add value, is it equally available to everybody across the patch, particularly in those communities where we've got people who might be less likely to go into a GP? And are we planning to evaluate it? So I know that the hope is and the intention that it takes pressure off primary care, but I'm really interested in how patients have found it, and if that could then inform any future scaling up or further rollout of it, if it does add impact and positive outcomes.
Thanks, David. Really good question. I've not got the detail in front of me, but this is exactly what we want to do. So as part of the integrated performance report, so that is as a metric, but we want to look at that metric by sort of different geography, different demographics. Absolutely something that we will be able to bring back. But I don't know whether Andy has anything further to add around the pharmacy first.
I wasn't going to make a point on Pharmacy First, except that I also love it as a GP. It's a very, very successful scheme, and it's having a really big impact, both in terms of the pressure into general practice. Obviously, pharmacy is a really important part of primary care, but it's a really well-loved and used scheme across the patch now, and it's growing and really providing benefit.
But we will bring that back in terms of the detail around equity and where there might be more usage, and there might be areas where there is not the usage that we want to see.
Will that come back through the performance, the integration? Yeah, lovely, excellent, thank you. So Andy, your yes.
Just on the Pharmacy First, we have got some experience and insight information. So we did some work actually speaking to people who've used the service, and there's a report on our website that shares some of the experience. So we've been working with that team to build on that learning and that experience that they've had. So just to let you know that.
No, thank you, Neil. Andy.
Yeah, thank you. So I do want to say a massive thank you to the digital BI team and the population health teams for providing this report. It made our job at Quality Committee so much more rich and in a way easier to do. And it helps us answer some of those so what questions that I was asking at the last board meeting. And I want to highlight just three things. The first is that when we're thinking about system improvement, and this board's done some work together with David Fillingham and Ailsa Brotherton and NHS Impact about how we can take more of an improvement approach, one of the things that I like that this helps us to do is to take an appreciative inquiry approach. What's working well? Let's celebrate what's working and how we can spread it and learn from it and do more of it. And I think that's a really great way to think about quality. What is the good quality that we can build on and we can learn from and spread to other areas? The second thing is that I think, yet again, this is demonstration that a population health equity with targeted interventions approach really works. So thinking about these lung checks, these are targeted interventions into communities where we know they have worse outcomes and worse healthy life expectancy and life expectancy. It makes such a difference that 400 people have been proactively found to have lung cancer at an early stage. Because if you are diagnosed at late stage in our emergency departments, which is the actual usual story for people in our most disadvantaged communities, your chance of surviving 5 years more of life is about 10%. If you pick it up in stage 1 or 2, we're talking about an 80 to 90% survival rate. What that means in terms of outcomes for communities and tackling health inequalities and people being able to stay economically active and available to parent their children and their grandchildren, these are real life changes for communities that drive down health inequalities and improve population health. This is such important and excellent work. And I think it answers that question. So it improves outcomes and it decreases cost. And I think I just want to circle back to the presentation earlier that Jen and Amy brought about the work going on in Claremont and this targeted approach and this proactive approach to communities who struggle with the most disadvantage. I suppose it's to highlight to the board, there is so much evidence that this approach works. And I think sometimes we're in danger of always, every time we start a new project, asking for more evidence that this is the approach we should be taking. We've got a plethora of evidence across Lancashire and South Cumbria alone now, plus reports nationally and internationally, that these approaches of targeting health inequalities work, improving population health, they do work. They're making a profound difference. We can see it in this report. And I think there's something about how we do scale and spread these approaches now, rather than every time we have a new project asking for yet more evidence, because the evidence is clear. A targeted approach into health inequalities through a population health lens makes a profound difference in terms of outcomes and driving down cost. And I partly just want us to celebrate that, but I also want us to note that the evidence is there and we just need to do more of this, more widely, as much as we can.
Thank you, Andy. Jim.
Thanks. 2 points really. The first one is this conversation is almost fundamentally why I wanted to be part of the ICB board, really. So the things we're talking about are so crucial to us. So I'm really pleased that the report is improved and it's going to the Quality and Outcomes Committee. And what you were saying, Sheen, about how you're looking at it is great. And I don't want to do that. I would like to see the report, though. So I think it'd be important for us to see, not to come to this meeting, but for us to have it as background for those of us who are not on the Quality and Outcomes Committee. The second point I was going to make, though, was a kind of request for the report that does come here. I think it's really important to have some volumetric data on this paper to make sense of it. So we're quoting percentages, for example, of the number of people waiting on 12-hour trolley waits. That's just abstract. I think if we put a number to that, it becomes much more real and it becomes much more of a priority. And not just on that, but in other areas as well. I think we could easily include a bit more volumetric data, which would bring this more to life than it currently is.
Yep. Thank you. Great. Great discussion. Thank you very much indeed, Asim. So we're now going to move to the Finance and Contracting Committee Escalation and Assurance Report. With Steve Igo having sent his apologies, I'm therefore very grateful to Debbie for giving us that report.
Thanks, Chair. So in terms of the AAA today for finance and contracting, there's a AAA for 2 meetings, the most recent ones, and then the committee also met on Monday this week as well. So I can add a little bit of a flavour just in terms of a quick update, but I think it's a November board meeting that will receive the minutes and then also the summary from that meeting. What you'll notice when you've read through is that the AAA for the committee tends to fall into 3 main areas. So there's always something around all-age continuing care because of the size of the programme and the risk around the delivery of it from a finance perspective. There's always an update and a look at the overall waste reduction programme, the WRP, and then we give an update because we're constantly reviewing and assuring against the financial position of the ICB and the system. So what I'll do is, rather than go into the detail, I'll sort of look at the latest one and just pull out a few key themes just for the board's attention, really. What you'll hopefully also notice is against those 3 areas there's normally an alert and an assure. So it would kind of raise areas of concern, really, but also give you assurance against it, which hopefully sort of creates a bit of a balance. So in terms of all-age continuing care, sort of on page 5 of the AAA, the update at the August report was that we took our usual look at this as a programme area and that there's good progress being made around the waste reduction targets that are in place. We are ahead in terms of, or we were ahead at the year-to-date position against the target. However, there's significant overspends in the pipeline, so the committee took a close look at that and also looked at the impact of accruals from the previous year and what those are having on the budget and the availability of services and the spend moving forward. We did take a close look at the delivery and execution of the contract compared to the plan and the forecast position. And in particular, we noted that there's a number of the schemes that are in place that are still high risk and haven't moved into delivery. So there's a close look in terms of assurance through the committee to see those where possible move into delivery, but also have a realistic view that if they aren't going to move into delivery and achieve the savings that are forecast, what the plan B might be across the ICB or within the service itself. The next area for the overall waste reduction programme, so the last update in August was that we looked at the overall programme, we looked at the mitigations in place. The delivery against the target for the waste reduction programme is moving forward, but again we noted the risk around a significant number of the schemes remaining high risk. And the longer that they don't move into delivery, the less time we have to actually achieve the savings through them. So it's something that needs to be looked at very closely, particularly given that the profile of it is quite back-ended. So that creates a significant cost pressure for us as an ICB as well. We took a close look at the mitigations that were in place and were able to offer assurance against that. The two areas of highest risk were around all age continuing care and prescribing, so we received detailed reports around it and we looked through the mitigations in place to support the delivery moving forward and the savings being achieved that were aimed. In terms of sort of the latest position around assurance, the meeting on Monday this week updated in both those areas, but it had a main focus around the forecast outturn for month 5, and also looked at a sensitivity analysis of the year-end budget position. So I won't go into that because Stephen's paper covers that next, but it was just to flag really that the committee was able to assure against that to support the board to have an accurate view and to be confident of the month 5 position. That richness isn't here today, but it will be shared in terms of that future update through the AAA. There are updates outside of those 3 areas that are obviously really important. So, for example, urgent emergency care and winter planning, we were able to offer assurance against that and update on the latest position with a further review to be completed. But I thought at least if I focused on those 3 key areas, with them generally being the main ones for assurance, it might be helpful just to try and summarise for you.
Thank you. Thank you very much indeed, Debbie. Any questions for Debbie? Specifically that I'm not seeing, it's probably best to move on to the finance report where I think that will be more clear for questions. So over to you, Stephen. Thank you very much.
Thank you, Chair. Yes, the paper in front of you is the position at the end of August 2025, so that's the month 5 position. The submitted position at month 5 was the system was £23 million behind plan, with the ICB being on plan and the shortfall against plan across a handful of providers. That is largely due to the shortfall in the efficiency programme. What's coming through is when we set the plan, we had a level of unidentified efficiency that was phased in 12th, and that's kind of coming through the position now. Through the assurance meetings from the ICB that we have with NHS England and the assurance meetings to providers, there are plans to kind of catch that up the remainder of the year, which is why we're still currently forecasting that we'll deliver the plan. Just in terms of the other area, in terms of capital, at the moment we're forecasting a slight underspend on capital. That'll be absorbed, that'll be picked up as we get further through the year. And then just the point that Debbie touched on, just in terms of the risk to the forecast, which is what we spent quite a lot of time on in the meeting on the Finance Committee on Monday, which we can bring to a subsequent meeting. At the moment, the providers have got circa 58 million of risk to the forecast. This has been done through a robust process. As I've referred to, this relates to the efficiency programme, but there are plans to mitigate that. From an ICB perspective, and again, it touches on what Debbie's discussed, we've got some risk around the WRP programme, the independent sectors overheating, and then all age continuing care, there's some pressure. But we've got a robust mitigation plan to cover that, and we'll be forecasting to deliver the plan at the year end. Thank you.
Thank you. Thank you very much. Any questions? No. No. It's good. In that case, we will move on to the next section, which is strategy and developing the system and strategy. So we start with an update on commissioning intentions.
Thank you, Chair. I'll take the report as read. So this paper summarises the continuing work on our commission intentions for 26-27. As you know, we've started this process some 5 months earlier than we have done in previous years. We've had a number of sessions with our teams, the leadership team across the ICB and board, and we've had 4 engagement sessions which have been invaluable. So just want to thank everybody who's been involved and for Neil's team in supporting those engagement sessions. Sections 2.4 and 2.5 describe those areas and also start to think about our strategic direction of travel, the vision for the ICB linked to the 10-year plan and neighbourhood health, and how we're going to work in partnership with our partners because for the wider determinants of health. So really thinking about framing this in a strategic context for the future. And we've also made sure that we've dovetailed this with our planning guidance because there's a lot in that about the left shifts and the 3 strategic priorities. We want to ensure that there's absolutely meaningful engagement. So we've got sessions planned post this board to work with our partners, whether it be our local authorities, our third sector and voluntary sector and other partners to think about how we align our commission intentions. So the work that we've been doing with some of our DASs that Kath referred to earlier about how we support the strategic framework for working together on some of our complex cases, mental health, learning disabilities, etc. Still in the early days, but I think some green shoots there, and I'm hoping to build on that work at scale and pace for next year. We also want to ensure that we really frame this, and you know, Andy constantly reminds me about our health inequalities. So what does it mean for our population health? And you will see that we've new criteria for our commission intentions. They need to be a part of the priorities of the organisation that links to our risks, but also it links to the 10-year plan and the national priorities. We've had a long listing session for commission intentions and now a short listing one, and we'll be sharing those drafts with our partners and our providers very shortly. And we are still on target to engage throughout October and November. Some of that, it does include our board engagement as planned. We've previously planned with signing off our intentions in December this year, which will be our earliest opportunity, and that gives us time to ensure that any contractual changes happen in the last quarter. This is absolutely part and parcel now of the planning guidance that we've got, and I'm not going to steal my thunder from the planning paper, but it dovetails, and we want to see next year a single integrated approach rather than 2 approaches working side by side. So that's the intention for growing the commission intentions for future years. So I'll pause there, and I'm happy to take any questions, Chair.
Thanks very much, Craig. Any questions for Craig? Yes, Sakthi.
Thank you, Craig. It's really good to see how we're defining commissioning intentions, especially section 3.5. I was just wondering, and we might want to cover this in the next item, given the 3 shifts, how do we overlay this? So if we are moving from treatment to prevention and hospital to community and analog to digital, what are the contractual changes in section 3.5 that will actually become reality? So it's mainly as an observation and also an offer from wider partners, both from local government and wider partners, so we can align our plans, given that it's happening earlier on this year. There's a real opportunity for changing the way we work together going forward. Thank you.
It's an absolutely really good point, and it's one of Jim's constant challenges to me about how we do some of this real left shift. So we've got some examples of it with our locally enhanced service and how we're looking for that shift. It is a challenge though, and I think we do need to think about not just the contractual levers, but how we do this within the resources that are often obviously quite tight. I do think there are a number of ways we can do this within the envelope, but it does require us to think differently and to work, especially with some of our providers, both across primary care and secondary care, and to have a good risk appetite to be able to move services into the community closer to home. So part of the commission intentions we want to be able to outline, they're going to be our priorities to do that, and this is how we're going to do it. And that's where we need the support of our partners. So the engagement over October is to build some of that granular detail on how we're going to do some of this, not just the what.
Thank you. And thank you, Sak, for the question. Sheena.
So just thinking about the sort of how we take our strategy, take the 10-year plan, And, you know, it's almost kind of, we could almost have had this after the next item, probably would have made more logical sense, but we are where we are. It's just thinking about how do we work across systems and take an integrated approach. And so I just wondered how you're thinking about, as we move forward in our operating model, about how you change commissioning intentions to be less about, although they're not entirely individual organisations, and much more about taking that population approach across an integrated sort of health outcomes perspective. Thank you.
And I probably will pick up some of that in the next paper. So you're right, Sheena. So actually, as a part of our planning, we do need to understand where we are from a population health perspective, the joint needs analysis, where the integrated care strategy will also play in, as you know, as a part of our partnership work through our integrated care partnership. We need to make sure we've got the clinical strategy as well. That is a hook for us. And we need to be clear about the delivery that is around our population, so the neighbourhood model. So we're building from the bottom up as well, from the top down. I think we've got a lot of the foundations laid for this work, but now it will be about turning that into practice. I think the good thing about the operating model and the planning guidance is it's come out early enough for us to be able to work in a way that's not trying to retrofit something, which has been a bit of the challenge we've had in previous years. So I think actually having the guidance now, the planning guidance, and saying you need to ensure that we've got work streams such as population health, outcome improvements and trajectories, as well as the clinical strategy, means that we can we've got a place for our commission intentions to be able to be anchored into, which we've not done in previous years. The proof will be in the pudding, and I'm sure the board will hold me to account on coming back to demonstrate that we've done some of that. But I think we've got a better opportunity this year to work in that integrated way than we have done in previous years.
Andy.
Yeah, just to comment on that, though, if I may, Chair, and I think we have to note the complexity that local government reform is going to throw into this mix in the next 2-3 years ahead, especially for Lancashire. I think in terms of co-commissioning and planning in West London and Furness, things are a bit more settled and secure, and actually there's a very more obvious way that we can begin to align plans and think about. But actually, in terms of local government reform, I think we just need the wisdom of SACFI and our other Directors of Public Health and Directors of Adult Social Care about how we do this well. I think it's actually quite complex in the changing landscape about what's going to remain priorities and what different parts of the how commissioning is going to happen within local authorities during that changing landscape, and how we can align around our places as they also develop over these next few months and years ahead. I think there's just a complexity we just need to be very aware of and work out how we tread carefully in that space and do the work up front together. So we really welcome those conversations with local authority partners.
Yes, no, thank you. Tracy.
Thank you. Yes, I just wanted to come in on that really, because we had an ICP meeting on Monday, and on the agenda very much was local government reform and the combined authority, and I think it was really useful for us to think about the context of that in the way you described there, Andy, and talk about the commissioning intentions with that complexity overlaid. So I think it really shows, I think for me, the need for us to continue coming together as an ICP, as an integrated care partnership, because those really are the spaces that lend themselves to those discussions and finding our way through some of that complexity. And I think probably thinking about as well how we can really build on what the ICP has started, and we talked about that as well, didn't we, on Monday?
Yeah, no, absolutely, thank you. Yes, Kathy.
It's just a quick one, and it's just in terms of the complexity, I guess, around Westmoreland and Furness. So although the South Cumbria part might feel quite simple, actually from a Westmoreland and Furness perspective, it's really complicated because we are across two integrated care boards and trying to make sure we've got equity of offer for residents across the patch when you'll be two different systems with different priorities. So whilst I get, yes, this bit might seem simple, it's not quite as simple as it is as that for me.
Okay. Any other thoughts on that? No. Thank you very much, Craig. So, on to planning guidance.
Yes, thank you, Chair. So, as I said, the planning guidance came out earlier this year, which has been a really, I think, useful timing for us, especially as we'd started our commission intentions early. What we've tried to do, and I've got a very detailed paper that I'm happy to answer any questions on, but just in relation to the highlights, we've brought together the strategy and the operational planning, which has often been seen separately. I've also dovetailed it, as I said, with commission intentions, which you've just heard, but also our joint forward plan, which is still a requirement for us to produce in the organisation. So there's lots of elements that we're trying to bring together under one sort of umbrella. We've got weekly planning oversight groups that I am the exec lead for, and that's to ensure that we maintain progress. We have flash reports that we must produce, and that it's important because that's where we're monitoring the operational planning, the neighbourhood health needs, the neighbourhood health plan development, the population health needs assessment and the clinical strategy. They're happening all over the ICB, but this brings it together in a multidisciplinary way throughout the directorates under single leadership, which again is I think a real improvement on previous years. We're not working in isolation. We've had some really good sessions with our provider colleagues on this and our provider collaborative, as well as working with our VCFSE partners. But just to highlight to the board, the timescales are very tight, and we've heard that the timescales have potentially changed only this week. Allocations have been delayed, so it does put us in a tricky position to make sure that we're meeting all of the requirements, and therefore we've been looking at capacity to make sure that we don't miss any of our deadlines. Obviously the board has a hugely important role in setting our direction of travel and challenging us on the plans, as well as receiving the assurance, and that's what I wanted to bring today. So the paper itself outlines the risk and mitigations as well. It talks about the direction of travel, and I've also included a section on the joint forward plan, because I think that's important previously that we're clear on where the joint forward plan's up to and its refresh, etc. So I'm going to pause there because I'm happy to answer any questions on the detail rather than just going through any more of the highlights.
Thank you very much, Craig. Just before I open it out, the planning, and it is guidance, not framework, but it is a really helpful way, if you read it carefully, to assess what our new role will be. And there are a lot of those areas that we've identified in our discussions that we don't currently do to build the bedrock on which to decide what our commissioning intentions would be. It's not that we don't do it, it's we don't do it consistently and in the right order always. So I think the process that we're going to go through is going to be a very useful one in terms of working out what we need that we don't have in terms of data potentially, but actually probably more in terms of capacity, structures, interrelationships. So I think I think it's going to be quite a useful process. Did you want to come in? Yeah.
So thank you, and I think it's probably really an ask really of some of our partners around the table really, because I think this, given some of the risks and the description that Craig's given of the timescales and everything else, and given where we are on the operating, because ideally we'd want to change the operating model, get everything in place and be all up and running to do this. And we've got some of the real foundations on this, some of the joint agreements we're now getting with the local authorities, which has been really great working with you, Kath, and others about how we're building some of that, and the meetings we've been having, Tracy, with the voluntary sector, and thinking about how we do that. And I suppose it's an ask really, because I know we've got these risks identified in the paper, and I think that is really important to have it, but it's really how do we know it's going to be a bit bumpy. It's not going to be the ideal thing this year. No matter what we do now, it's not going to be absolutely perfect. It will be the start of something that will then grow and develop. So is there anything else that people think, and it might not be for now, but just thoughts of partners, how do we make that the best it could? Because it could be quite demotivating to have this and then feel that we're not engaging as well as we should be in this, because there's so much opportunity. And I know we're going to do engagement events and other things, but is there anything more we should be doing to make sure we're all in this together and we're working through it, because it's going to be a little bit bumpy, I think.
Yeah.
Thank you, Sam. Okay, I've got Debbie, and I think I saw some other hands, but you might need to do them again. First, Debbie first.
Thank you, Craig, for a comprehensive plan in terms of how we're approaching it this year. Just a plea from me, can we make sure we do not lose sight of the importance of workforce planning? That's one of our, sustainable workforce is one of our risks on the BAF. And this process and making sure we think about our multi-year workforce planning is key to this. Thank you.
Absolutely.
Thank you, Debbie. Yeah. Saxi.
Thank you. Just wanted to reflect on a couple of points that responds to Sam as well as what Craig presented earlier. If you step back, this is a 10-year health plan from Department of Health and Social Care. This is not a 10-year NHS plan that we are seeing in front of us. And we must remain conscious of that if we were really to leverage the wider resources in the system to improve health and reduce inequalities. It's quite easy to get drawn towards, we need a plan, and the ICB and the NHS. We all know that that only goes to a certain extent in improving outcomes and reducing inequality. So I just want to make sure we don't lose the distinction between a 10-year health plan and the NHS planning that sits within that. The second point here that's not quite come up so far, which is in the NHS as well as the 10-year health plan, is this neighbourhood health plans. And if you look carefully in the national guidance, the neighbourhood health plans are owned between partners, and the role of local authorities, role of voluntary community faith sector, role of the wider public sector, indeed wider economy, if you think about what influences living well, work and health. And the place to do that is highlighted as the health and well-being boards, which is at the upper tier local authority levels in the national policy. So we just somehow need to align the timescales without slowing anything down, but be aware that there are other expectations of other big partnerships, which speaks to how it all links through the ICP and so on and so forth. And there is a lot of refresh work happening alongside the new operating model for the ICBs within local authorities, certainly in Lancashire County Council. But I know it's happening in other places as well about refreshing the role of health and wellbeing boards. And I think we need to start seeing the relationship with the ICB board and the health and wellbeing boards as an important dynamic in actually laying out the foundations of what improves health, which then starts to inform the joint forward plan, the commissioning intentions, the population health improvement plan of the NHS and so on.
Yeah, I think it's a really important point, Saxi. Andy.
Yeah, just building on Saki's point, completely agree with him. And I think it's also about how we then take the appreciative inquiry approach to what are we already doing well in neighbourhoods in each of our places that we could actually draw from that inform the plans. So how we take that learning from the way that we've been working in Rylands, in Lancaster, with many of Sakthi's team and Mark Davis's team at Lancaster City Council and Yak Patel's team in Community Voluntary Faith Sector, and how we take that learning from Barrow and what we're doing with Kath's teams over there and with the Community Voluntary Faith Sector, and how do we spread that? How do we do more of it? What are the lessons that we can all learn from, and how do our health and wellbeing boards say more of this? Let's spread this learning rather than thinking we've got to start from scratch and design something from the top. Actually, our teams on the ground are already showing us how this works, and how therefore do we build that into planning and take almost like a disruptive approach rather than a on-high approach. That's the first thing. The second thing is really building on Debbie's point about workforce and a wider issue actually in her role, which I love partnering with her on in her role as CPO. There's something in the planning here that we need to make sure not only we're thinking about health inequalities, but particularly what kind of health inequalities. And there are things that we need to build into the planning that we're not always very conscious of, but we need to be deliberately conscious of. For example, our work around anti-racism, our work around people living in and with disabilities and learning disabilities and autism, or our work around women in particular and the disadvantages many of our women are experiencing. So there are things that we need to be particularly cognizant of as we plan our work, that we are not just being aware of, but deliberately targeting how we work with our plus communities. I think, again, also of the LGBTQ plus community across Lancaster and South Cumbria. There are some communities who suffer significant inequalities, and if we don't plan to mitigate that, we will continue to see that worsen. And so I just wanted to highlight those points into our planning guidance as well. Thanks.
Thank you. Good. So lots of work, but feels like the right direction of travel. Absolutely feels like the right direction of travel, and really good to have such interaction and conversations around the table with partners as well, and knowing that those are going offline as well. So thank you. Okay, urgent and emergency care delivery. Craig.
Yes, it comes round very quickly. So this is our UEC delivery and winter planning update. It is in two parts, as it is here for approval because there's a board assurance statement that the board do need to approve. But I've got four key points that I just wanted to run through. It's a very detailed paper, but that's a requirement for us in relation to planning for winter this year as a part of the UEC national strategy that's been published. So just to remind members of the board, national priorities: reduce ambulance wait times, so that's the Cat 2 response, in 45 minutes, achieve 78% for 4-hour A&E performance, reduce 12-hour and 24-hour ED waits, and improve discharge processes and timely care for children. So that's been a helpful frame for what we need to do in relation to our interventions. We've developed a whole range of winter planning arrangements and activities. These have been done collaboratively through our UEC improvement plans. They're managed by our UEC delivery boards that are in the footprints that are very much integrated boards. Some of them are jointly chaired. Kath is one of our chairs for the board. So this is not just about health picking up sack at the NHS. It is truly about health and social care wrapped around the people in our places. We've got a focus area on patient safety and risk, vaccination, infection prevention control, system working, primary and community care, mental health and hospital discharge. We've stress tested some of these plans through exercise Aegeus, and we've done our lessons learnt, and we've got real-time monitoring now through our system coordination, our SCC centre, which is here across from the offices, using our Opal framework. So I'm able to go in and see exactly in real time what is happening across the system. And we've got, through Wendy Lewis, a continuous improvement process in place now that's made a massive difference. So that's ongoing work. We do have some risks in relation to operational and financial pressures. They exist, and they exist each year. And also one of the big challenges, obviously, as we go into winter, where we see some of our performance stretched. So I just want to remind the board. There is potential funding and investment in relation to the Regional Transformation Fund, so there has been bids in that are supporting our UEC delivery, so we're just waiting to see the outcome of those. And we've obviously invested from our UEC capacity investment funding to support hospital avoidance, flow and discharge, which again is very positive, and currently what we're hearing and seeing is a positive impact of those. And as I bring monthly updates, as I've done every year, we will make sure that they're measured also against the impact changes, so we can see the so what, how is it making a difference to the system. The final bit, Chair, is just the board assurance statement. So winter plan needs to be in. The board assurance statement is included. I am the winter director for the ICB. We've got a central point of contact within our strategic coordination centre. We need to submit the board assessment, so it's important today, by the 30th of September, and we've made sure and received assurance that all of our provider boards are all doing the same, so they've had the same template and they will take it through their boards. So that's a part of our assurance, assuring that their boards have done it. I'm happy to take any comments or questions, Chair.
Thank you, Craig. And this is for approval.
Yes.
So thank you. Questions, thoughts? Jim?
It's a comment more than a question, really. It's a conversation I was having with Neil earlier around the consultations on shaping care together. And the kind of the big issue Neil said was coming out was not so much where A&E is situated as the patient experience people have when they're in A&E. And these are all kind of almost like numerically driven things, but we somehow need to also reflect on how we improve the patient experience, or how the providers improve the patient experience. And if we can somehow build that into the exercise we're doing, that would be really helpful.
the continuous improvement work that I said Wendy has been undertaking picks up a lot of the patient experience working with Neil's team, so we can bring more detail on that in the future because I think it's an important point, Jim.
Thank you. Yes, Kathy.
So we've taken a leaf from this board's book in the Urgent Emergency Care Delivery Board for Lancashire South Cumbria, and we've actually introduced the voice of person. So we've started now also to have lived experience, and there's been some fantastic examples of work that partners have done that have had a real impact, but then to hear from the person as well, it brings what can sometimes be a very performance data type meeting to life and really brings reality to what it is that you're trying to do. So, yes, so I just wanted to share that with you, that we've pinched that with pride from here.
Excellent. So, I'm not seeing any other hands. Yes, Andy.
Just a quick comment from me. I mean, Wendy has led some brilliant work on this, and she comes regularly to see us as the medical directors across the system, and they are really fully bought into and leading this plan across the trust. So I just wanted to offer some assurance that there really is a good join-up between Craig's commissioning team and the medical directors across the trusts to make sure that this is really being implemented and that these experiences of patients as well are really being considered front and foremost.
Thank you. That's important. Sheena.
Yeah, I just wanted to just sort of look at one particular group of people who come to A&E departments, and I'm thinking about people with mental health needs and often comorbidities. And Chris raised earlier the question about how well connected were people into the different ways of accessing mental health support. And I just wondered what particular thought had been given to focusing on that and the particular target that is within to reduce waiting time for people with mental health needs to less than 24 hours. And 24 hours is far too long, an hour is too long. But I just wanted just to understand a little bit more about what work's been done on that. And also, that's a huge bit of experience as well. Thank you.
Yeah, thank you, Jess. Well, I can update Sheena. So I suppose from an assessment perspective and timely assessment within ED, we score really well, meet the national standards for assessment. The issue is then when onward bed is required, and that's that balancing act, I think, at the moment, between bringing down out-of-area placements and timely access and clinically ready for discharge, and that's the system balancing act that we're managing on a day-to-day basis. With regards to making sure that experience within EDs is as best as it can be. Within the 10-year plan, there is an ask that that systems have mental health EDs. This is something that we have trialled, and it's had mixed response over the 5 years I've been in the system. That said, we are repiloting mental health EDs. So there's 2 of our EDs, so Blackburn and Blackpool, that have purpose-built units that could be used for mental health EDs. They won't be used for patients awaiting a bed because they don't have the facilities that you would expect, but they should be used for patients that can be assessed with either where a potential assessment and then onward to referral to service or discharge from mental health should be used. So that's our Chief Operating Officer at the Trust, Donna Robinson, is linking in with the Chief Operating Officers at both Blackpool and Blackburn to trial in one, and then for the next to be the fast follower. Within the other EDs, there isn't that infrastructure, though we have got capital bid in as part of the planning. That helps.
Just like, if we may, just to sort of, because this is sort of an area that doesn't always get focused on, if we could perhaps through our reports going forward, and obviously it's something we'll pick up as well through Quality and Outcomes Committee around understanding how that's moving forward, if we may. Thank you, Emma.
Absolutely. Yeah, thank you, Sheena. Tracy.
Thank you, Chair. Yeah, I wanted to pick up kind of the other end of what you're talking about and talk a little bit about how some of the UEC plans are actually trying to tackle issues so that people don't end up at ED with mental health issues. So some of the work that the VCFSE have done, and I think it will come to a later board in its entirety, because there's a lot of evidence around the work we did last winter and how we're planning what we're doing this winter now on the basis of that. And last winter in Blackpool, we concentrated very much on respiratory as a key reason why people ended up at A&E, and linked with the acute respiratory infection hub at the walk-in centre. And this year what we've done through a lot of the evidence that we've gathered and looking at need, we've expanded that to cover CVD and mental health. So we're looking now at ways in which we can work in the community, work alongside our primary care partners and various other partners to actually implement things where people just wouldn't end up at the door of A&E. And some of that, as you would imagine, is those wider determinants of health. Some of it's around making sure people have got suitable housing, that they're having the debts dealt with, all of those things that obviously try and mitigate against mental health crisis. So I think what we'll find over this winter, actually, and again, take your point, Chris, about linking in with the initial response service and all of those other services that wrap around individuals to try and make sure, actually, because we all know that ED is not a place for anybody who's in mental health crisis. We need to do more in the community to make sure we're preventing people ending up there in the first place.
Thank you. Thank you very much indeed. It sounds very good. Sam?
I just wanted to make a point, Tracy, because we met a week or so ago, didn't we? And I suppose I was just reflecting on the conversation we had about some of this, and one of the things that's been quite successful, and we haven't quite cracked it with the whole of the sector in terms of trying to get you more integrated into it, but one of the areas that has worked is the UEC funding, and one of the reasons that worked was because we were able to topsize some of that to allow some thinking through the sector to think about what you could do with the resources. And it wasn't a huge amounts of money, but it makes a big difference. And I'm just thinking it's one of the positive learnings that I think we've had, and something that really works that's come out around allowing that, and it's something I'd like to think we're going to continue with. But I just wonder whether you wanted to comment on that, because you were able to do so much more and engage in probably the best way we've been able to in some ways through that, by releasing a bit of resource through this work.
Thanks, Sam. Yeah, I could probably talk at length, so I'll keep it quite short. I think there was a few things that were really key learning in this. There was a real leap of faith with this, because actually this money was kind of given to the VCFSE Alliance for us then to come together and make decisions about where this money goes, to work with population health teams and local authorities in place, and to actually look at, well, where can we make the biggest difference this last winter. So we targeted Blackburn with Darwin around falls, frailty and complex lives, and Blackpool around respiratory. And what we were able to do was really harness those organisations who we knew could kind of hit the ground running. And because it was done through the sector rather than it being quite a top-down approach with the NHS, what we were also able to do is push back on some of the metrics and say, we can't report on some of the things you'd ask a trust to report on. And actually we were really listened to as a kind of a collective voice in that. And what then we were able to do is say, well, actually, we've got metrics ourselves. And we had a managing agent in this, as well as Spring North as an organisation, who were then able to really go all out to collate all of the information we needed to look at the metrics that we'd said we'd measure. And the report that comes out of it that I'm hoping to be able to bring to the board is incredible in terms of what it's telling us. I think I don't want to steal the thunder of it coming to another board, but I think we were able to demonstrate over 400 emission avoidances during that period. And that in itself, I think, really does play into this whole idea of how are we doing things differently? How are we moving the dial on some of this? And I think it was very much that different approach. And it took a long time. We were round the table, myself and colleagues, right from the very beginning of all of that work around planning what we were going to do around UEC. And I think that's what made the difference. And we weren't just round the table as isn't it nice to bring in some voluntary sector colleagues? We were round the table and listened to, and actually people said, yeah, we really understand that if we're going to make a difference, we are going to have to free up some of this money, because I think the way sometimes we think about the solutions, we think about it through the lens of the NHS. And if we can only think about it through the lens of communities, of inequity, of health challenges that aren't being addressed, and the things that Jen and Amy were talking about, that's where we do some of this magic.
It'd be great to see that report, and it'd be great to continue and learn and progress with this. But thank you for everything you and your colleagues have done on that, because it's been really good. Thank you.
Excellent. Good. So, I think, are we happy to approve the winter plan? And we look forward to receiving monthly updates. I think given the richness of today's discussion, it would be good to include, I'm not necessarily asking you to do that, Craig, but to include some of the wider work that's being done through our partners, and perhaps get some of of you to talk about how it's feeling at your, either in your areas or from your perspectives, so that we build on that richness of discussion. Great, thank you. Okay, I am going to plough on till the end because we only have one more section, and then we are likely to finish early unless we get very excited about the board assurance framework. So moving on to the governance section. First of all, the Audit Committee Escalation and Assurance Report. Jim.
Thanks. We actually had an audit committee meeting yesterday, and there's quite an overlap with the meeting that was held on the 23rd of July, so I'll try and integrate the two together. We talked about the new ICB financial system at both, and it was an alert at both meetings. It actually does go live next week. Sam mentioned it earlier. The team have actually risk assessed this at 16, which suggests that there is quite a potential for things to go wrong. And we think there may be, hope they're not, but there may be issues around some payments. And I think we also need to be aware that the financial reporting will be affected for a couple of months. So we will not get the full range of, well, perhaps not as accurate financial reports as we've had in the past, basically. So just to be mindful of that. All age continuing care, which has come up at almost every discussion we've had so far, was also discussed. We were congratulatory of the work that's being undertaken, but from our perspective, we would like to be able to take a better perspective on the overall integrated action plan, and the conversations that are taking place and how we can do that. We had a series of internal audits that were completed, including one on data security and protection toolkit, which was given an overall assurance of high risk, but the veracity of the organisation's self-assessment was high confidence. So we're quite worried about the fact it was given a high risk. But then when we talked about it, the high risk is kind of driven by a formula. And if you fail two of these kind of little gates, then you are automatically high risk. We were then assured that there is work underway, some of which has been completed to address the issues, and a more detailed action plan will be going to the IG group next month. So we weren't as concerned when we heard that. On special needs, educational needs and disabilities, there was we got moderate assurance, but there's an element in there about the extent to which we comply with statutory responsibilities, and Sheena's going to take that to the Quality and Outcomes Committee to make sure there isn't any issues on that one. From a business community perspective, the committee are going to look at the effectiveness of the ICB's business continuity arrangements, given everything that's going on. So hopefully that will come back to the December meeting. We noted the Information Governance Annual Report. There's an awful lot of good work going on in the Information Governance team, and it goes unnoticed, really. It only gets noticed if something seriously goes wrong. And actually, nothing really, I mean, touch wood, but nothing really went wrong in the 12 months for the report that was covered. So that's, again, it's well done to the team involved in that. We talked about artificial intelligence and the increasing presence and importance of it. There was a very good paper came to the Audit Committee, and we feel it should be disseminated much wider. And there's also a recommendation that foundational AI literacy be provided for all staff, which again we supported. So it is of growing importance in the healthcare sector and almost in the wider system, really. There was a reference made to whether we need a group to look at the ethical implications of artificial intelligence applications, which Sheena highlighted this for me, so thanks Sheena for mentioning that. And it was suggested that this could be achieved by forming some form of ICB ethics group, broader remit than AI, but something where issues could be considered. So I think that's to be borne in mind. And we agreed the updated anti-fraud, bribery and corruption policy, which includes the new corporate fraud offence re failure to prevent fraud. So it was quite a full meeting yesterday.
Yeah, thank you very much, Jim. Yes.
Thank you. Great report, Jim. Thank you. I thought there's one more thing to consider, though, when it comes to AI, which is not just the ethical considerations. We have to be net zero by 2040. And AI takes up a phenomenal amount of non-green resource. And it is driving climate change significantly in the wrong direction. So there are not just ethical considerations, there are climate change considerations for us to consider here. And we need to think about, if we're going to be truly a 2040 net zero organisation, what that means. There are really significant implications for us to consider. And I don't know where, I guess we'll have to take it to Alistair, or I'm not really sure where we put it. But it just needs to be considered in the round because it's actually a huge piece of work.
Yeah, so we have probably one of the best pieces of work we do across the system is on our green plan, and Alistair does lead that in the States. So I think it's about feeding, and I'm sure this is on that agenda anyway, but I think we will absolutely need to feed that into the aspects of the green plan. That gets refreshed every year anyway, but we do have quite a robust green plan, but it's a consideration for there, I think, Andy.
Thanks, Sam. Stephen.
Yeah, just an update on the new ledger. So we're in what is called a cutover period. So the old ledger, which is ISFE 1, closed yesterday, and the new one opens on the 1st of October. During this period, there's a process called emergency payments where NHS England can make payments. So I think that's probably come out since the risk rating. So I think the risk we discussed as an audit committee is 16. So I think it was a concern during that period when we had to make payments. Obviously, NHS even made the point that you've been aware that you couldn't make payments during that period. So if you had to do, you can obviously pay people in advance for the remaining week of the month. So I said, touch wood, I've just asked the team, do we plan on making any emergency payments during that period? But there is a mechanism, should we need to.
Thank you. Any other questions for Jim? No, a wide-ranging agenda there, which is important and good. Okay, we're now going to move to the board assurance framework. Well, it's much wider than that, actually. Sam.
Thank you, Chair. And I am going to get a little bit excited about the board assurance framework because it is such a lot of good progress. And thank you so much to Deborah Atkinson here and her team for the work that's been to support us as a board on this piece of work, really. I'm not going to go through the whole report, but I think what the report provides is a refreshed update on the board assurance framework. And there'd already been some really good work reflected by auditors, actually, on how this is coming together. But it follows quite a lot of work we've done as a board, as an executive team, in terms of really looking at considering and reviewing the risks that we have on the board assurance framework, the way that we score them, the way that we think about them, how we describe them, and also to consider what's happening in the wider context. So a bit of that horizon scanning, because it's very easy just to look at the risks that we have through the operational ways in which we work. And actually, we have quite a considerable changing environment around us at the moment. And so we've considered those landscapes, the environment, and the future direction in assessing these risks. And I think it's been a really thorough exercise that we've been through. So that work has come together. It's gone through several iterations through exec teams and board development sessions. And that has updated, and we've now got 8 key risks on our board assurance framework. And those are the things that we should be using to drive the agenda of this board, because if we've got it right, then we're looking at the right things. They should be, and if you look at those 8 areas that are identified in the report, you'll probably recognise we've been talking about them for the last few hours, and also in our private board as well. And they are the key things that are on our agenda. So it makes me feel quite assured and a little bit excited that we have something that's working quite well. I think the only caveat I'd put to that is that because of that changing environment, your board assurance framework has to be driven by the right strategic objectives. And at the moment, we've got 6 strategic objectives. And the proposal in here is that we don't change them at the moment because there is that changing piece going on. We've got the 10-year plan landing, the planning that we've been talking about, also new chief executive. And so there's a lot of change going on. And so there is a recommendation in here that with the new model blueprints and the information that we're still sort of finalising nationally, really, that they stay in place for this year, and it still frames our board assurance framework, because the risks are all against those strategic objectives. When you look at them, though, they can't be wrong. They're quite high level, but they are about our quality, our outcomes, our money, or they're the things that matter. But I think they will become more sophisticated as we go forward, and I'm sure this board now, in the coming months and years, will really start to tighten up and home in on the strategic objectives that this supports. But not only have we done that process, I think that the team under Deb's leadership really has looked at how do we continually update those and strengthen the control environment around this. And there's quite a bit in there around templates and the way that we describe risk, but using that cause and effect so we can really articulate what those risks really mean. Not just this is a risk, but this is a risk, and this is the cause and this is the effect of that risk, and describing it that way. So I think the board, in doing this work, part of the work that we also looked at, because what's important, particularly when we're facing into making difficult decisions and some of the things that we're doing, it's really important that we understand the risk appetite that this board has, and some of the work that we've been doing really sort of has defined that. And there is a statement somewhere in the pack that talks, the last page, that talks about our appetite for risk as a board, and it's really important because we can reflect back on that when we're making decisions and think about whether we're taking the right decisions collectively. And they're not fixed as absolute, we've got to, but they are really now a good guide to some of those decisions that we might want to take, and what sort of level of tolerance we have against that. So the ask today really is really to recognise and note the work that Deborah and the team have done to support us with this, but to agree to leave the 6 strategic objectives as they are for now for the reasons I gave, while we do the strategy and blueprint, and to agree the statement for the risk appetite and the refresh BAF and the 8 key principal risks. So that's the ask for today. Thank you.
Thank you. Thank you very much, Sam. I said to you yesterday, it's very often very easy just to sort of dismiss the board assurance statement. It's such a fundamental document if we use it properly, and they are quite often quite difficult to read and quite difficult to follow. And this one is quite clear, actually. So I take the point about the strategic objectives, but I do appreciate the amount of work that's gone on through you, the executive team, we as a board, and also through Audit Committee. So I think it's a good piece of work. It will develop. It will always develop. It will always improve. But so I'm going to ask for any questions or comments on the board assurance framework as it is. If there are any sort of queries about it, and then we are looking to approve those items. Saxi.
It's just triangulating all of this back into the performance and how we measure as well. And one of the things that strike me is it's all great, fantastic that the thinking has happened. But one or two things like neurodevelopment pathways, don't quite link back into KPIs. So just a suggestion, or I'm just noticing that's something for us to consider.
Yeah, no, I think that's absolutely, and should be a natural consequence of using it the way we intend to use it. Any other thoughts or comments? No, are we happy to approve this then? Great, thank you. Thank you very much. Okay, so now we have the seal next. Yes, use of the seal. Stephen. Is it Stephen or is it? Yeah.
Do you want me to take that paper? I can take that paper.
Yeah.
We have to report the use of seal to board, so that is what this paper is doing. The seal was used in relation to the Health Innovation Centre lease, an extension for 1 year, and that was done under the signature of our Chief Exec Sam and CFO Stephen. So it's really just to bring that through for transparency and good governance.
Great, thank you very much. Okay. And then finally, the report concerning matters considered in private board meetings, which I am... Oh, sorry, is there a question? No.
I was just apologising. I didn't have my mic on when I did that last paper.
Yep, so the last item, report about matters considered in private, and importantly, I'm very pleased to see this is a lot shorter than it has been in the past, reflecting the fact that we are have the need for less of those conversations that we did. But over to you, Deb.
Thank you, Chair. Yeah, and again, I think we're familiar now with this report as a standing item, and it really just summarises any matters that have been discussed in private. There have been 2 occasions since our last board meeting in public, and they're summarised, the topics are summarised under section 2. And again, I think similar to the BAF, we can see that all of those areas have been part of discussions, either at the last board in public or at our meeting today. I think just to note, on the there was a single item board on the 6th of August, and whilst the board did approve a voluntary redundancy scheme, that hasn't yet been approved by NHS England. Thank you.
Thank you, Deb. Any questions? No, thank you very much. Any other business? No. Items for the risk register. Has anyone picked any items up? I think we've, having just considered the risk register, is there anything that we've missed on there? I think not. No? No? Okay, fine. Thank you. Some really good discussions there. And particularly great to hear so much from our, I never remember the right term, but those of you that are not, what is the right term? Regular participants. I never can get my head around that word. But no, it was really good to hear from our regular participants so actively today. So thank you very much for that. See you in a couple of months, and actually see you quite soon at the AGM, hopefully, most people.